Dr. Delvena, help. Your brain love really needs to be felt. Serve me on, don't make me feel on myself. Brain food, brain sleep, neurology health. Brain love on me. I need you to assess, diagnose, and treat. Reveal what's underneath. Some brain love will give me peace. Prescribe me something, doc. Ooh, baby. Brain love on me. Brain love. Yes. Brain love. Yes. Brain love.
Ladies and gentlemen, this is Rick Party introducing my friend and board-certified psychiatrist, the host of the Brain Love Podcast, Dr. Delvena.
Hola, good evening. So what's 2 words you learned in the last 5 minutes? Brain love, yes. Everything is about brain love. So when you leave here, if this is your first time coming this evening, you'll leave and you'll remember brain love. So if we had time, I would ask some of you, what does brain love mean to you? But maybe Cozy or Kennedy already did that. So thank you for coming out tonight. For those of you who don't know me, I'm Dr. Delvena Thomas, a board-certified psychiatrist, and a mama, and a soldier in the Army Reserves. So, all right, y'all ready for the show? So, Dr. Linda Green is here, and as you all know, who knows Dr. Green? Dr. Green fan club in his house. Okay, Dr. Green, you got your mic, right? All right, so before we go any further, I want you all to please subscribe and follow, well, I should say follow on Eventbrite. This is a QR code for our foundation. We also have Instagram and Facebook. Please follow us so you can find out about all of our events and everything we're doing. And this is me. I have a podcast. It's called The Brain Love Podcast. It's been on since Mother's Day 2020. It was during that Black Swan thing that happened. They called it a pandemic. And, you know, we were all at home. I was driving into the hospital and stuff, but traffic was wonderful. Traffic was good. But, you know, so many bad things happened during the pandemic, and people were really struggling. A lot of folks who had mental health challenges, those things were uncovered during the pandemic. So my son and I were in my computer/studio/office, and I said, I should do something for Mother's Day today. So I started this podcast, and I think the first episode was about the best hip-hop song for Mother's Day. So I played Tupac and some other ones. So the podcast has been on since Mother's Day 2020. It's on all podcast platforms: Spotify, Pandora, iHeartRadio, Google, Apple. There's probably about, 60, 70 people in the room. So when I leave tonight, if you're not already subscribed, I should have some new followers. I check my statistics. I stay on it. Like, how these people show up? I only got 1 new Spotify follower. So please follow the podcast. You don't have to listen every week. A new episode comes out Sunday night at 8 o'clock. Enough about that. Okay. So we got some champagne. Josh said he's going to come up and refresh our glasses when it's time. And just as a reminder, I'm leaving this picture up. Dr. Green, you have patients in the audience?
Just a few.
Okay, Sora Gaines, that's my prez from previous. So she's part of the folks who made me, if you understand that. My Spesh is in here too. Spesh, where are you? And some ladies from BCAC. Yes. All right. So Sora Gaines, that you are or were her gynecologist? Yes. Woo. 25 years.
Stop telling my age. But we might have to have some skivvies in here too.
Oh. Well, I'm sorry. Do we? I don't hear anything. Oh. Okay. So good. There's love in the house. I love it. Yes. Colette. So Dr. Linda Green is a board-certified obstetrician, gynecologist, and a fellow of the American Congress of Obstetricians and Gynecologists. Dr. Green earned both her undergraduate and her medical degree from Brown University and completed her residency at Kaiser Permanente.
With those two, mind you.
Oh, with those two? Who? With Dr. Mumford? And who's sitting next to you?
From when I was 16.
Yes.
Dr. Mumford actually taught me to drive.
Yes.
You can't make this up.
Dr. Green has been practicing as an OB-GYN since 1990. I was entering high school then, so thank you. And so, yeah, I mean, this is a hard business to be in, especially in private practice. Yes, ma'am. And has been in Coral Springs since 1991. She has served as vice chair and chairman for the OB-GYN department at Northwest Medical Center. She served many years as a physician reviewer for the state of Florida. Dr. Green performs minimally invasive Da Vinci robotic surgery, including myomectomies and hysterectomies. She has a son and a granddaughter and loves to travel and also practice yoga. And in fact, when I called her to ask her if she was available this evening, she was traveling. For an OB-GYN, you travel a lot, ma'am. Cheers.
Cheers. I was actually in Big Sky with the National Brotherhood of Skiers, which is the largest ski organization in the country. Happens to be a Black ski organization, by the way.
Oh, this champagne is delicious.
So definitely NBS.org. You guys should start skiing. We're trying to get a Olympic skier or sporter or, you know, some snow sports Olympian. That's the goal of the organization, 50 years old.
Wow. I went skiing once, but I didn't go skiing. I just hung out and went down the hill on the tubes and all that stuff. Yeah. That part. So ladies, we're in here tonight to talk about menopause. How many ladies in the room are, and you know, I know we don't like to share our ages, but listen, if you're able to share your age, that means you're living. You're thriving and you're well, you're breathing. When someone asks me, how are you? I say, I'm walking, talking, breathing, and wiping my own ass. And that's, you know, it means a lot. It says a lot. So I am 48. I turned 48 in January. We were here a couple of months ago, and we were talking about some of the symptoms of menopause. And I think it was you or Dr. Stitt said, if you're waking up a lot during the night, going to the bathroom to pee. And I was like, oh my gosh, am I starting menopause? Am I there? So let's talk about menopause. What is menopause?
Menopause is the cessation of menses, and it can start having symptoms for years before you actually stop having periods. I was 48 when I became menopausal. I'm 62. So I've been actually on hormones, just as a disclaimer, for 14 years. So we're going to talk a lot about treatment for menopause. One of them is hormonal therapy. So, you know, it's been a lot. In that 14 years that I've been on hormone therapy, there's been a lot of bad press about it, a lot of miscommunication. And so I'm hoping tonight that we get to clear up a lot of that, you know, just misinformation.
So at what age do most women or the average woman start menopause?
Average age is 51, but it's normal after 40. Unfortunately, I treat some 25-year-olds who have premature ovarian failure, which means that their ovaries just don't work anymore. They've shut down. They're not going to be able to have children. So if you see any women that tell you, oh, whatever age they are, my period just stopped, they still can have premature ovarian failure and they need treatment. Those women, it is not controversial. They need hormones at least until the time when they would have gone through regular menopause, which is age 51. So those women should have hormones, period, because they age, lose their bone, they do all of the nasty things, unfortunately, that we have happen at 50s, whatever age that happens.
So menopause is cessation of menstruation. Mm-hmm. Women stop having that monthly visitor, as a lot of us call it, or menses. How much time has to pass before one would say you're menopausal? Or
when a woman comes to my office and she's been without a period for a year and she says, aren't you going to test my hormones? I'm like, no. You're menopausal by definition. That's the definition, is 1 year. Now, one thing we're leaving out are women who have hysterectomy, because women who have a hysterectomy sometimes don't realize, hopefully they've had their ovaries retained. So they have their ovaries, and so they still are going to become menopausal. However, they're not going to have to stop menses because they're not menstruating. So when will they know they're menopausal? That'll typically be symptoms. So all the symptoms we're going to talk about for menopause. So you still need to seek attention with your physician, even if you're not having periods, if you're starting to have menopausal symptoms that we're going to discuss.
So we hear about early menopause, we hear about perimenopause. Mm-hmm. For the normal age person who's entering menopause, when do they start experiencing those symptoms?
Prior to stopping their periods, usually I'd say 2 years. They can start having something. If you're going to have something, there are some women that go through menopause and like your grandma might say, I didn't have anything happen. Nothing happened. I was fine. I don't know if they're in denial or they're just stronger than us, or if they just ate better than us. Who knows? Or they grew up in Japan where they have a lot of edamame and a lot of soy, so they don't have as many symptoms. But there are many women that just don't experience anything. But the majority of women do have some symptoms from menopause.
And what type of symptoms should we look out for?
Anybody want to yell them out?
Wait, say it again. What was hot flashes?
Hot flashes is number one. And typically at night, so it disturbs your sleep. So you sweat. That's why everybody's selling all these things, cool blankets, cool this, cool fans for the night. But there are many other symptoms. So women can come in sometimes and they can just say, everything hurts. So you can just have joint pain, muscle pain. You can have palpitations. I have many women that just have palpitations. There's so many symptoms. And a lot of times people just come in and go, my belly just got big. What happened? My belly just blew up, right? And, I'm eating the same, I'm exercising the same. So there's just a constellation that it almost makes me say, what's not a menopausal symptom? Because and you have to trust your body. You know what you're going through, you know what's happening. So when people poo-poo you and blow you off, you go, okay, next doctor, next therapist, because I know my body.
Yeah, for mental health, when women come in who have never experienced anxiety before, never had challenges with their mood, with sadness or depression, I find that a lot of them will have fluctuating moods. And they feel the sadness and they can't explain why. There's nothing wrong. They're happy at home. They're multitasking. They don't have financial issues. And then it turns out when you start asking questions, because during your first appointment with your psychiatrist or your psychiatric nurse practitioner, we always ascertain or gather your medical information. We don't just ask you about your social history, your family, and your psychiatric history. We also want to know how many times have you been pregnant? How many children do you have? When was your last menses? We're asking you all these things. And I think also what we know that menopause can also affect our moods and affect us psychologically.
So as gynecologists, we don't say depression, but we say decrease into well-being. Yeah. So the studies say that you just don't feel yourself. You feel almost like out-of-body experience. You just know something's going on. You don't have control. And it's not like you're not getting out of bed. It's not like you're dysfunctional, but you just know you're just not, you're a little anhedonic. So you don't have as much joy in your life as you did before. And you're like, why? Everything's great.
So for early menopause, so we're seeing someone who's 47, 48, 49, they will experience some symptoms that's leading to menopause. And I guess a year or so later, or 2 years later, they'll stop menstruating. What do we consider early menopause? I know you mentioned the 25-year-old.
Younger than 40.
Okay. So if you're 40 and above and you have cessation of menses, menopause is considered average or normal?
It's a little early, so you want to have treatment, but it's normal. It's not genetically abnormal.
Okay. So less than 40 is early menopause. So when someone comes into you and you determine, okay, yes, you haven't had your menses in a year, you are in menopause, you have the symptoms, what are the options in terms of making them feel better?
Okay, so it's a whole long discussion.
You have time.
Thank you guys for giving us this time together. I feel like at a family chat, so it's really comfortable. First, you have to do a symptom diary, right? Because people may come in and they don't know this is from menopause. They don't know, they think, oh, I don't like my husband anymore because I'm unhappy, right? No, it's not your husband, it's not your dog, it's just your hormones. So I try to do a symptom diary, like exactly what you're experiencing, how you're sleeping, because they don't realize that, they think they're getting up to go to the bathroom, but they're really waking up with a hot flush. So many women have sleep disorder and it has nothing to do with menopause. So really a sleep disorder that is reflective of menopause is you wake up and it feels like there's a volcano, right? Like it's just a volcano and it lasts like 1 to 2 minutes.
I don't wake up and feel like there's a volcano, but I wake up. And I notice that I've been waking up more during the night to urinate. I do notice that.
I wouldn't, if you came to my office, I wouldn't necessarily say that was menopause. So I wouldn't want to start talking about your sleep hygiene.
Yeah.
I'd be like,
I sleep well, lady. I sleep 8, 9 hours.
What time you go to bed? There's no TV in your bedroom.
9 o'clock. I have no televisions in my house whatsoever.
Ooh, good for you.
No TVs, y'all.
Yeah.
No. If my son, if he wants to watch something, it's on his laptop or on his phone. We don't have televisions.
Good for you. I was good for that until 12 with my son, but now we have a TV. But, you know,
every so often I'm hot.
Yes. So it really,
probably more than I want to admit. Somebody laugh like, you hot all the time, girl.
So, but it should be strikingly different. So it doesn't necessarily have to be that you sweat or anything like that, but you feel hot and then it resolves. So if that's happening, that's a hot flush. It's just not a very severe one, but you feel hot and it resolves. If you're just hot all the time, that's not a hot flush. So it has to resolve. You have to be like, oh, thank God that's gone. I don't want to put my head in the freezer, because you literally want to do something like help me, like it's a panic. I remember I had my first hot flush. I was on a plane going across to Europe. I thought I was going to die because I didn't expect it. I was not menopause. I'm like, I'm going to have a heart attack. I'm going to die right here on this plane, because I just felt like this rush of adrenaline, and everybody was asleep on the plane. I'm sitting there, don't panic. You're okay. So it may happen in areas that you just are like, what's happening to me? So you have to consider that. If you have something like that happen and it resolves, it very well could be a hot flush. But there are many other symptoms, heart symptoms. A lot of times women at menopause, all of a sudden your lipid panel, you go to your primary doctor and your lipid panels are up 30%. You're like, I have not been going to Popeyes. What's going on? Right? And I'm exercising the same, but my cholesterol's higher. So there's, many kind of more silent things, restless leg syndrome you can get in the night. There's just a whole constellation of symptoms that you really have to talk with your physician about. And a lot of times people don't realize it until they're on a treatment and they go, that was my menopause, because they feel better.
So that's a journal you're asking them to keep so they can keep track of their symptoms and I guess the time of day it's happening, how long it happens. Okay. Are there stages to menopause?
Well, there's really just perimenopause, and women want to say, I'm through menopause, right? Sorry, you're not. You're never through menopause. Once you're menopausal.
Wait. You said you're. You see how she tried to just gloss over that? You're never through menopause?
You're either premenopausal, perimenopausal, or postmenopausal, right? Okay. You're never not menopausal again. You're menopausal. So 15% of 80-year-olds will still have hot flushes, which sucks. That means 85% will not. But 15%, if you're untreated, of 80-year-olds will still experience, vasomotor symptoms, they're called, or hot flushes. And what happens is slowly the changes that occur at menopause kind of worsen in every organ system. And we can go through all those organ systems together.
Go ahead. We're on a roll.
Okay, well, our brain, right? When our brain has less estrogen, we notice that our brain shrinks. We don't have as much blood supply to our brain. We have something called cobweb brain. Like, you're just like, wait, I can't really get through this puzzle. You feel like your cognitive function is decreasing. And we actually do find that women who are estrogenized have better cognitive function and their brains are actually larger. So these are things that all of the people that are talking to you about hormones don't necessarily tell you. They tell you the stuff that's scary because they don't want you to sue them if you have a stroke or a heart attack, but they don't tell you the good things, right, about a hormone replacement.
Doc, before you, so while you're on the brain, I read something recently that mentioned there are studies that show women who enter menopause early menopause are at higher risk for dementia, early onset dementia. The neurologist is there too. Is that?
Yes.
That's a good study, yeah. Okay.
Yes, I believe that's a good study. So yes, that is true. Well, we can go to the heart. We also have increased risk of cardiovascular events. Now, a lot of the studies are talking about how we're at more risk if we're taking hormone replacement, estrogen particularly, for cardiovascular events. And that can be true if you have some pre-existing history. Like, my mom had a heart attack, my dad had a stroke, but you have to also talk about yourself, because our parents lived in a different time ago. They ate very differently. They exercised very differently. So, you have to evaluate your own health, and you have to decide whether or not you really are that person that has cardiovascular disease risk that's great enough that you can't take hormones, because all-cause death is decreased when women are on hormone replacement therapy. All-cause death.
Say that again.
All causes of death are decreased when women are on hormone replacement therapy. Cardiovascular, stroke, everything is all-cause death is decreased. You don't ever hear that, do you? So there's secrets, and I don't really stock in hormone replacement companies. I wish I did, but we just need to not stop having the misinformation. And of course, there's risks, and I go through those risks with. No one comes to my office without walking out with a paper of the only study ever done, the Women's Health Initiative, that says you may get 8 more clots out of 10,000 women. You may get 6 more strokes out of 10,000 women. You may get 6 fewer colorectal cancers. You may have, 10 more heart attacks, out of 10,000 women. And I say to them, if those numbers frighten you, then you should not take this medication. However, there are, I take it every day, and I'm willing to take that risk. You may not be. And because I'm doing it because it improves my quality of life. So it improves my health span, right? Not my lifespan, but my health span, my ability to sleep at night, my ability to not have painful intercourse, my ability to not get up all the time to go to the bathroom, my mental health. It improves many things. And it's not for everyone, but I just want people who are able to utilize it to not be frightened.
So you mentioned painful intercourse. Let's talk about that.
Okay.
Break down, why do women have painful intercourse?
Okay. So what menopause is a loss of estrogen. So estrogen actually affects all of our tissue in our body. It affects our skin, right? Our skin gets saggy, right? We notice that, I'm crepey places. Well, it happens internally as well. So the wall of the vagina, let's say it's this thick. As you go through menopause over time, it gets thinner and thinner. And what does the top wall of the vagina do? It supports the back wall of the urethra, or the tube that drains our bladder, right, Dr. Monfort? So you go to her office and she's going to say, even if you're not on hormone replacement therapy, let me just give you a little estrogen to put in the vagina. It's going to help your bladder. It's going to help support your bladder so that you have less leakage, so that you have less frequency of going to the bathroom, because that wall is going to be more supported. It's going to be thicker so they can bring more blood supply to fight infection, so it can have more, be less traumatic when you have intercourse, because there's more cushion for the pushing. Right? So what happens to a lot of women is, even if we don't get a UTI after having intercourse, we get a urethritis. That's what I find at menopause. A lot of women come in and say, I have a UTI, I check their urine, there's nothing there. I culture, it's nothing there. They're like, yeah, but it was horrible and then it went away. You're inflamed because there's no cushion, right? And then a day later, even if you don't go to the doctor, you feel better. If you have a real UTI, it's not going away. You're going to keep having one, and you're going to have to go in. But you'll notice that after intercourse, you just are not comfortable as you used to be. So you either have an inflammation or urethritis, inflammation of the urethra that resolves in a day or two, or you have an infection because there's less fighting cells there. There's less macrophages, less white blood cells, because there's less tissue to support and to bring all that supporting, antibacterial support that your body needs to send to those tissues to protect it.
Yeah. So for the ladies who are in their 20s and in their 30s, and they're like, I'm sitting in here for this menopause talk. I'm not menopausal, but they're thinking about how they can kind of ward off or prevent menopause from early onset. What can young women do to help delay the onset of menopause? So you mentioned Japan and Asia and China and the tofu and the soy and all of those things. True or false?
True. Soy is a phytoestrogen. So it is a naturally occurring plant estrogen that basically treats you. So when women don't want to take medication, I will tell them, increase your soy. Have a soy glass of milk before you go to bed. Have edamame. Increase the soy, because that's naturally going to provide some more estrogens for you. And that's what happens in Japan and such. But menopause is genetic. So when women come in, I say, how old was your mom at menopause? Because likelihood, you may have had a very different time of menarche, of having your period, but you're going to get your menopause around the same time as your mom. Unless, the only time I find that's not true is when the mom has had something traumatic happen. And that can put people into menopause immediately because that's just stress. But in general, you're going to go into menopause around the same time as your mom. So you should ask. And so I find that particularly heartening for me. I have two very good friends who had babies at 46 and 47. Right? And that's because their moms had menopause at 58, both of them, 56 and 58. So they still maintained their fertility. So that just brings up another just quick thought that there's a lot of us that are older now. I have so many women that are 40, 42, thinking of having pregnancies, right? So ask your mom when she went through menopause, because that's going to help you determine, in addition to the testing that we do, the longevity of your fertility.
So you just mentioned testing. What kind of testing is done when someone comes in and says, listen, I think this and blah, blah, blah is going on? What
Very
testing
simple.
you're on?
It's just two tests, something called follicle stimulating hormone and estradiol. So the follicle stimulating hormone is produced in the brain, and it tells your ovaries to produce estrogen, produce follicles, make a baby. Now the estrogen returns and says, okay, I've made enough, and it gives the brain estrogen. If the brain doesn't get the estrogen, it goes, wait, I need more estrogen. So it starts yelling at the ovary. So the FSH level goes up. So once your FSH level goes up, it doesn't go back down. It's because it slowly increases. So the follicle stimulating hormone is elevated when someone's in menopause, and the estradiol level is low. So those two tests.
The hormone replacement, you mentioned it. You touched a little bit on that, how it can help us. And then you mentioned the bad rep that folks, the rumors and I guess the urban myths, or not so mythical, but what are some of the concerns with hormone replacement therapy? Why are some people dismissive or oppositional to HRT for patients?
So the reason is that they're very afraid of heart attack, stroke, and breast cancer. Everybody's terrified of breast cancer. We all should be, right? 1 in 8 women by age 80 get breast cancer. The real truth is women who are diagnosed with breast cancer who are on hormone replacement therapy actually have a better prognosis. Now, why is that? Nobody really knows. We can suppose that maybe it's because it's picked up a little earlier, because it's growing a little faster, because definitely estrogen is a little bit of like plant food to breast cancer. But women survive more who have been on hormone replacement therapy. But the real truth is a very small amount increase in breast cancer in women who are on hormone replacement therapy. And in fact, women who take estrogen alone, those who have not do not have a uterus, because if you don't have a uterus, you don't have to take estrogen and progesterone. You only have to take estrogen. I'll explain why. Those women have no increased risk of breast cancer. Okay. But just like when you were younger and you're taking birth control pills, unfortunately, we're not as good at this, but you go to the doctor, here's your pills. We don't say, you can have a stroke. You can have a heart attack. You can. It's estrogen. But we know that if you get pregnant, there's a higher risk of those things, right? Of having a stroke and heart attack. Of course, we know pregnant women are more higher risk for other things, so we don't have those discussions. But when you come in as a menopausal woman, we're going to say, you know, there's this certain number of risk of breast cancer, of stroke, of heart attack. And women don't hear there's decreased risk of osteoporosis, right? Because estrogen is very good to the bone. It helps your bone stay thick. We don't hear that, 29% of women who fracture their hip after 65 will die, right? But we're not paying attention to the treatment or prevention of osteoporosis with estrogen. We also don't hear that colon cancer is decreased with the use of hormone replacement therapy. So I almost say, when I look at the studies, I say there are 2 more cancers. There are, for example, 8 more breast cancers, but there are 6 fewer colorectal cancers. I'll take my chance with the breast cancer. I could see it. I could feel it. The colorectal cancer is a little bit harder to diagnose. I have a very good friend fighting it right now, my age. Had a colonoscopy 7 years ago. Just had another one, colon cancer. So do not sleep on your colonoscopies, ladies, because Cologuard will tell you if you have a cancer. A colonoscopy will find the cancer before it's a cancer, just like PAPs. So don't be afraid of your colonoscopy. It's a 6-8 minute procedure, and it can save your life. Anyway, that was an aside.
It was actually the best 6 minutes of my life when I had my colonoscopy. They gave you some propofol. Yeah, I mean, you sleep. Who's had a colonoscopy and wasn't that induction good? Yeah,
it's good.
They put in that IV and tell you, and 2 count down from whatever, and then you're out and you wake up and you don't even know that it happened It's like the next morning and you don't realize it happened.
You do not feel anything, ladies. Nothing.
You don't feel anything. Hi, Josh. Thank you.
Oh, he's.
Yeah, you haven't been
up.
drinking. Peer pressure. Drink.
These ladies will tell you that's not a problem.
Thank you, Josh. Clap for Josh, guys. Give it up for Josh. Yes. So let's talk about some alternative things that we can do to help ease the menopause.
Okay. I'm going to just talk about the newest thing out there you guys are seeing in the news. There's something called Veoza, which I really do like for women who cannot take hormones or have chosen not to. Or honestly, I had a patient come in yesterday. She's early 60s. She told me about how much she was kind of shamed because she wanted hormones. And now she feels much better. She doesn't have much symptoms. She has a few symptoms, but she still wants something. So she's someone in her 60s, because that's when there's more risk of heart attack and stroke and all that stuff. I would say, you kind of missed the boat. Sorry you didn't take the hormones. But I would give her Veoza. So Veoza is an NK3 receptor agonist, and it works in the brain. So it works in the thermoregulatory system, and that's the system that is affected when we have hot flushes. So it kind of shuts down those thermoregulatory. So I'm not saying it's going to help your vagina. I'm not saying it's going to help your mood. However, if you get sleep, that's going to help your mood. So that's something that if mostly the hot flushes is the problem for you, that's an alternative. Prior to that, we were using medications like Paxil. I was using it at a low dose, 10 milligrams. You might use it at 40 milligrams or 60 milligrams.
I actually hate Paxil, but the benefits
the benefits are good. We also use, I was also speaking to somebody about using clonidine. Intensivist. She was saying she has these women in the intensive care unit that have hot flushes, and she wants to treat them. So clonidine is something that we use as an antihypertensive. We also use it as an anti-anxiolytic, and it's something you can also use to help flushes. Those are things that I typically will use. And, we use other things. Sometimes we use any of the other antidepressants, but those are kind of my favorite ones to use.
All right. So I think I have a video.
It makes the guest nervous when she puts on videos.
Shoot, no, not that one. There we go.
I'm a board-certified OBGYN physician, and I would love to know your thoughts on this. Since I've become menopausal, it's really made me think hard about my training. The lion's share of the hours, time, and study was spent on helping people get pregnant, keeping them pregnant, and then delivering the baby. We only spent a small fraction of our time studying anything to do with menopause. More women will go through menopause than actually have children. Most women will spend about 30% of their lives in menopause. Yet we receive the barest minimum training about this subject, about the nuances, medications, lifestyle changes, all the things made to keep women healthy as they age. Medically, it seems to me that the value of a woman somehow plummets once she's done with childbearing. I'd love to know your thoughts.
I'd love to know your thoughts.
She is 100% right. And do you know why? Number one, we need studies. Nobody has chosen to do studies on women. So when you're studying in medical school, everything has to be peer-reviewed, level 1 evidence. Oh my goodness, right? So when you're presenting those to physicians that you're hoping are going to be operating, and they're, operating on knowledge, not on, something that doesn't have level 1 evidence, you can't present it because you have never done the studies to prove it. So I could say the same thing about nutrition. Doctors aren't taught about nutrition, by the way, right? So, there are many areas that, and we certainly aren't taught about the difference in nutrition for men and women and what's needed. So, there's so many things. For example, I'm going to go on with the systems if you don't mind.
Sure.
Once you go through menopause, you start getting metabolic syndrome, right? That's where your belly blows up. You get this insulin resistance. Everything you eat can't, it goes right on your stomach or your hips. We don't have any studies about that. We don't have studies about, maybe you should take anti-inflammatories like turmeric. Maybe you should be taking omega-3s, right? Maybe you should be taking, Dr. Lassie is doing a functional medicine fellowship, right? That's the kind of stuff that, I want to go to a functional medicine doctor. Help me prevent illnesses, treat me with food, treat me with alternative treatments, make sure I'm getting the probiotics, because we all know, and this is luckily becoming common knowledge now, that everything's inflammation. So everything's inflammation. So we should all be on turmeric every day. We should all be on probiotics every day. We should all be on collagen peptides, right? Because we are going to fall, most of us. And the thing that happens at menopause is all of a sudden we start losing bone, like 5% the first year, every year thereafter 2%. These years are just flipping by. So 2%, 2%.
Like for Titus Unlimited, I'm taking collagen peptides from his nutrition company.
Well, I'm not taking his, but I'm taking some. Who is it?
Titus Unlimited. He's been on some of these shows in the past.
Okay. So we should all be on collagen peptides, right? We all need the protein, because what happens as we age is additionally, we lose our muscle mass, right? By like 70, you're going to lose like 25% of your muscle mass. So what's going to happen? What's happening to our mothers? They're falling, right? My mother fell and broke her hip at 70. She died, right? We are falling. We're fragile because we're doing the same things, and we have to stop. We have to start doing new things. We have to start doing weight resistance. We have to stop trying to be skinny and start trying to be strong, right? So that's the thing. We have to start eating protein, and doing, not running on a treadmill, but doing squats, doing lunges. Jumping rope is amazing for your bones. Like, yes. I want to buy this little thing that's a vibratory thing. Jumping makes your bones strong. So you can just stand on one leg and hop, right? That's going to help strengthen your bones. When you're home talking on the phone, it's very simple things. When you're watching television, do 10 lunges. When you're in the shower, I was trying to do 25 lunges in the shower every day. It not only gives you a cute butt, it strengthens your hips. It works. So, there's so much that we have not studied. So you can't teach medical students about things that you think. You have to teach medical students and residents about things that you have researched and that you can tell them is really true. Anyway, I'm sorry, I went on.
No, that was great. Wasn't it? Give it up for Dr. Grain on that. I love all the prevention. That's what it should be about, is prevention, and not this reaction in the Western medicine of giving a person a pill for everything. We have to do more than that. So I do want to talk about sexual health. And how we can maintain our libido, our sexual activity as we're aging. Because I think a lot of women and men believe that as we grow older, that we can't be intimate anymore.
Very not true.
Yeah. So I think you've seen this before, but...
When it comes to sexual satisfaction, all the focus seems to be on men. Well, this one is for the women. Hormone specialist, our friend Dr. Christopher Asandra, joins us with his patient Gabrielle to show us a procedure that claims to improve female orgasms in just an hour. Dr. Asandra, I think everyone's ears just perked up a little bit.
Yeah, they did.
So tell us, Chris, how exactly does this work?
So this is the Delvena shockwave sound device. And what it does during the treatment is stimulates new blood vessel and nerve growth in the female parts down there. And the result, increase in frequency of orgasms and the intensity of orgasms, and also helps with lubrication as well. So I wanted to kind of demonstrate it a little bit on a peach here, just so you can kind of hear it and kind of see what happens during the process. So you can see it's not causing any damage to it at all. You feel a little bit of tapping sensation that most of you see. It only takes about 4 sessions that are less than 10 minutes each time.
And Dr. Asandra, a treatment that has been used for men in urology for erectile dysfunction issues, prostate issues. It's also used in orthopedic surgery, musculoskeletal issues. And like you said, you're causing these micro traumas, which in turn cause healing, which means increased blood flow and increased collagen, elastin, all those good things.
Absolutely. And we do see when the studies show that the blood vessels actually expand, we see new nerve growth and everything else that comes along with it.
All right, get started, Dr. Sandra. And
there we go.
Gabrielle, hopefully you can talk while the treatment is going on. So tell us, what does it feel like?
It's like a suctioning, tapping feeling. And there's no pain at all. I was initially concerned when I first started. I thought, is this going to hurt? But in fact, it's sensitive because it's a sensitive region, but there's absolutely no pain at all.
All right. And as we understand, this is your third session. So tell us, what sort of response have you had? Have you noticed any changes?
I have to tell you that the time between the first treatment and just driving in my car, I was surprised to feel that area down there in general felt more alive and more sensitive. And every treatment after the first one has become even more heightened.
I need to know the joke. Why are y'all
and also, as far as climaxing is definitely feeling like how it used to feel. So I'm very, very satisfied.
Tell us, Dr.
She said very, very satisfied. So, Doc, you have some kind of device also, right?
I have that device.
You have this one. Okay.
And it does work.
And it does work.
It works more by... So I have another device actually works as he described, which is called the Mona Lisa. Smile, right? But those are two different things. The Delvena is actually shock waves. And so those shock waves, we think, regenerate nerves. So they use it for men, right, Barb? In fact, my son was saying, this is our new Get Rich Mom. We got to open up a clinic where we just do it for men. We're doing that, yeah. But now, of course, they have it for women because men will pay. But the Delvena actually does work, and it's not painful. And I use a female to do this treatment, not a man. And because the tech really does it, the doctor doesn't do it. And honestly, at the end of the treatment, I actually leave the women in there with the end of the device, and most women will have an orgasm right there on the table. Yeah, but it definitely over time improves the innervation of the clitoris.
Hold up. Time out. Flag on the play, because I'm still listening to the orgasm right there on the table. But I'm sorry, Miss Gaines, what? Do you guys see her on the? She's like this.
I said she had an orgasm. That's what I said.
She did?
Yeah.
Oh, she did. I'm sure she did. That's what she said on the way home.
Okay. So on this show, he introduced this, or he discussed this in relation to a woman who's in her older years. Mm-hmm. So let's say it's a woman who has not started menopause, mm-hmm. and she's anorgasmic. Can this help a young woman who's anorgasmic?
I do believe that, but number one, you want to check her testosterone levels, right? As you know.
Did you guys know that you need testosterone? Yeah, you need that. Your sexual appetite requires that.
However, testosterone alone is ineffective without the use of estrogen. Mm-hmm. So when they did studies with women who are estrogenized versus women who are non-estrogenized, the effectiveness of testosterone is not the same if you're estrogenized. If you're not estrogenized, I'm sorry. So using, I'm happy to give women testosterone. I think it's necessary, but they need also estrogen in order for the testosterone receptors to work. So yes, I think that this could definitely be helpful. For postmenopausal women, I use another machine that's called the Mona Lisa, and the Mona Lisa is actually helpful to stop pain, because I have a lot of women come in and say, I can't do it. I'm in pain. And they don't know why. All of a sudden, they'll say, something happened in my vagina. It closed, or there's something in there. That's my favorite. There's something in there. I'm sure there's something in there. I'm like, there's nothing in there, okay? It just tightened up, and you don't have the rugae, ergo, it went from this to this, right, like we were talking about. So there's no distensibility. There's no stretchability, like when you had a kid and everything stretched. And so we need to bring that back. So we do that not only with hormones, so I can give you a small amount of estrogen in the vagina twice a week, but we also use the Mona Lisa. The Mona Lisa is a laser, and it actually does the damage like he was talking about, very targeted damage in a circular motion, 5-10-minute treatment to bring back the thickness of the wall. The Clearvana is shock waves, a little different, and it treats only the clitoris. So, you know, if money's no object, would you not want to have both of them once you get menopausal?
Wait a minute.
For sure.
Did you guys realize that Clearvana was on her clitoris?
Yes.
I thought it was somewhere. Oh.
Cleo.
Oh, you're right. Duh. Clearvana.
Yes, ma'am. Yes, but you know, it's an instrument. It's not like it's right there, but it's around the.
Okay.
Yeah.
I thought it was the vaginal walls.
No. It's on the outside.
Oh.
Yeah.
Okay. Got it. I'm sorry I interrupted you.
No worries.
Did you finish what you were saying?
I did.
Okay. So, yeah, it's 8:05. We talked a lot. We covered a lot of information. And I would like to open it up to the audience so that we can do Q&A if that's okay. Yeah. Are you okay with that?
Yes. Yes, please.
Okay.
Well, no question and answer session for you guys tonight. We've already been talking for 50 minutes on the couch with Dr. Linda Green. We will be back and you'll get part 2, questions and answers to this menopause session with Dr. Linda Green, MD, obstetrics and gynecology. So be sure to return. We will be back on the couch and you'll get all the questions and answers. And they were some great questions and some amazing statements, including a young lady who had spontaneous orgasms. We'll be back next week. Brain love.